bone level implants. And at that time, we also wanted to have experience with those, but today, otherwise the same protocol as Professor Buser. These are 10 millimeter, 4.1 bone level implants. I'm insisting on that because you will see in the X-ray later on the problem. You see a very little axis problem here, huh? But largely within what is normally done. Huh? Slight different. Okay, we take then the impression and we get the 3-unit directly screw retained temporary back. Don't worry. And what do you think? A lot of teeth, you know? It's bulky, it's toothy. I was really disappointed. I said, oh, this is just not fitting to her. And I let her stand up, go to the mirror, and she smiles. And then we took the photographs like this. And I said, why do you smile? It's not nice. And she said, I'm so happy that I have again fixed teeth and not the removable denture. And I say, well, but this doesn't fit. This is just too much, too bulky. So in the same session, we tried to remove as much as possible. And then I wanted to look also if pink can help a little bit, because the length to width ratios were just not correct. And this is just to show you how we do the diagnostic. Unfortunately, pink light curing acrylic is not available in many shades. This is the Espe Symphony material, which you see here, and it's a little bit too saturated. So we mix it with a flowable incisal composite to make a very pale mix, as you can see here. And then with an Explorer, we just let it flow in the proximal area. See, it just flows in like that. And then we continue and bring it up here so that we have the zenith really distal, that we get this triangular aspect. That's the purpose of doing that. And we know we can use pink until here and until here. So we will bring in here a little bit, here, here. And we continue, and then we let the patient, so we did a very, very little amount of pink here. And then the patient goes again in front of the mirror, and she looks if this is improving, if it's worthwhile. And if she says, well, it's not a big improvement, then we don't do it. Otherwise, we say we go then for that in the final restoration. You can easily pop it off if you have used glycerin gel to lubricate this before applying the pink. Then we waited several months until we took the final impression. And again, look at the edentulous area, the pontic area. That's how it's conditioned during the temporization, that we get this continuous line and a concavity so that we can harbor a convex pontic. Once again, you see the slight axis discrepancy between the two. Okay. And this is the restoration. And you see there has been some grinding been done necessary, which the technician will not tell you. But it shows then that the crossfit connection is not fully engaged on both implants. If this is of concern, I don't know, but I have seen much worse. I have seen really cut off a lot of that so that it went in. And then I think it is of concern. That's why, again, I'm rubbing it in. I think that the tissue level implants is the more appropriate one for these multi-unit restorations. And you see, ultimately, we only used T-type pink, just a little bit of pink in the papillary area. And this is at the try-in. And you see it's a little bit too prominent it sticks out. So we go and with the burr just slightly bring it as far to the palate as possible here and there, so that it does look more natural. So we did that, and then I let you judge her smile now. Now I think it looks decent. It's a very, very little thing, but just the triangular aspect of the neck of the T makes the whole difference. And now she's happy and we are happy, and I think that's ultimately she went through a lot of dental work, but I think it's a decent result. It's getting more complicated now. I still look 50. Okay, I have to speed up a little bit. Here you see again the impact of missing pink. And this is a picture I have taken almost 30 years ago. And what is the difference between right and left? It's this. Are you familiar with that? Okay. Because we had in Zurich at the university a technician, Aldo Lovi, who was an artist when doing silicone masks. And I know that you have in the UK also a few very prominent people who know how to do that when they deal with epithesis. But at that time, I was just newly appointed professor in Geneva, and then the head of Perio came to me and said, listen, I have a patient who had an aggressive form of periodontitis, and we did a lot of surgery now, it's stable, and you come from Zurich, you know how to make silicone masks. Can you not do this for this patient? And I did, and she was happy. The technique, I don't explain in detail. It needs a special way to take the impression, and then the technician can, on the same model, make 15 if you need. On the same, you press it, and then the patient has a stock for several years. And I did not see the patient then for roughly almost 30 years. Okay, that is the pictures I took then. I scanned them to make this presentation. Then I saw her back 2 years ago. She was followed by the periodontist in private practice, and he called me and said, well, she had an accident and she fell down. She had a fracture of the maxilla, which has been treated, but I cannot keep her upper 6 teeth anymore. They are mobile, they migrated, and there is separation. Please help. She's a very, very wealthy woman. You would not say that, but she lives for many, many years with these teeth. She said, well, whole my family knows me like this. Everybody likes me like that, and yeah. But it's amazing now. She has a huge class 2 division 1. And the whole segment now came down. And you see, from the premolar area on, everything looks normal. It's just the 6. And I have to extract them, but before I can extract them, which is very easy, of course, I need already to have a denture in my hands, which I cannot try in before. So I took Alginate impressions, mounted in the articulator, and then debated with the technician how much should we correct, length and overjet. And we said, well, we cannot do too much. Eventually this will look horrible for her, and it's too much of a change. And so I agreed with the patient to give her an appointment on Thursday afternoon, saying that if the denture, which only I can put in when I've extracted the teeth, may be entirely wrong, and then I can take alginate impression and do it in the lab for the next day, so that for the weekend you will have that. So on this Thursday she comes, you see, that was the dilemma, to decide really how much overbite and overjet should the removable denture have. And this is just gut feeling and a little bit of experience, and we just did this on the articulator. And then on that famous Thursday, I removed the teeth, which was very easy, of course, and placed the removable denture. And what a relief. It went in and was stable and looked good. And this is just the picture. There is about half an hour in between. Where you see now. And she went to the mirror and she said, why did I wait so many years? She was so happy, and suddenly she says, it's no problem. Also, my grandchildren love it, and everything is fine. When she came to a control, this is the patient 2 weeks later. And at that moment, she says, well, you know, when I walk in the street and I see a mirror or a window, I always look at this, and I like it so much. Actually, I'm happy with this removable denture. Then I said, well, I should also say that she's 87 years old. And I said, but we said that we will place implants and make fixed teeth. And you will see it will be so much nicer if you have nothing to remove. And they said, oh, yeah, of course, do so. But I would have also kept the removable denture, the temporary one. Okay. So, to make a long story short, how many implants? Now we are 6 missing. What would be the logic choice? And I will tell what Buser said. What would he have said? He said, it's clear, there's only one way to do it, 3, 1, 1, 3. And then you can segment, you can make 2 3-unit bridges, but that is what you should do. Okay. And what do you think I have finally decided? 2. I said, the 2 canines, she's 87. And I only want that these implants will outlive the patient. More I don't need. That's my personal. So I made exactly that stent, which we do always in Bern. And because the periodontist in private practice, he said, I would really love to place these implants. And that's how she came back. I did even say more O than you. On the upper left, it was exactly as planned. And then I called him, and he says, yeah, I know you will call, but the ridge was so undercut, I would have went out apically, and I wanted to stay in the bone. And I know that you prosthodontists, you always can fix it. This is, yeah. And now I'm really in trouble. I really hate it, because Buser would have placed it exactly where I need it, and he would do the fenestration GBR without any problem. Okay, now I have a huge axis problem, and I had to take impression. And this is what I got back from the lab, 6-unit, directly screw-retained temporary restoration, and her smile. And it was, again, not looking good. And look how bulky we had to make it on the canine, because I didn't want to screw through the labial aspect. Now I'm really in trouble, because when you compare it, that's how she came. That on the upper right was with removable. And now I have this, and it's by far the nicest is the removal. Huh? And so I thought, well, now we have to try to make as good as we can. And I had a long session where I tried everything. I shortened what I could shorten. I removed what I could remove. I put pink, as you can see, very small amounts of pink here, just to get a little bit rid of the bulkiness. And what I did also, because they looked so long, that I looked where her medium smile line is, and apical to that, I just removed. And always do it from out to in, so that we don't create shadow, that we don't lose the contact with the ridge. Never shorten it different, otherwise it will not look good. Okay, and ultimately, I came up with something which I think was more or less okay. And then we made the final prosthesis. I want to hear another "oh" now. Did you see it, huh? Because we were debating this on the lunch break with a few colleagues. Please tell me what you don't like here. Okay. What is that? That is how it should be, huh? And this has been chopped off, huh? And you see, you can imagine that the whole load is now basically on that screw. Patient is absolutely not occlusally active, luckily. I can just, to make it long, this is already 3 years in mouth, and no screw loosening, no nothing. But it's just pure luck. In another patient, I think I would have the phone call very early. You see, this just shows the limitation of multi-unit restorations for this implant design, which has this beautiful, look, I love the CrossFit connection because it's deep and you can blindly go in with components and you feel the resistance, you turn and you fall in. Then you know it's seated. You don't need an X-ray to make sure that your impression coping is perfectly seated. But this is typically an implant which is designed for single restorations. For me, it's clear, this connection, with all its benefits. And if you have multi-unit, I think it's a second choice. Anyway, she has not a very high smile line. Tissue level implants is for, and when I showed Boozer, I said, wow, why did you let him place bone level implants? And say, well, periodontists, they just wanted to use the modern implant, but it's not the best design for them. And what you see here is after 2 BISC try-ins, it is not great, it's okay. When you have 6-unit restorations, already have 2 BISC try-ins, if you then ask the technician once again to do modifications, and he will tell you, well, I cannot go into the furnace anymore. And then you have to start from scratch again. And with no guarantee that the second attempt is the better. What I want to say by this is, whenever possible, try to avoid huge units. That's an old prosthodontic rule. Smaller segments are by far better. And so I convinced myself, particularly with this extremely wealthy woman, she could have paid the 4 implants without any problems. Huh? And now we have this. And she came to the master class in Bern when I finally placed it. And then we are very objective. Which one is still the nicest? Upper left, huh? Also upper right, enjoy upper right. You're not. Okay, upper right. By far, it's the most harmonious. And I mean, what she has on the bottom right is okay, and she's happy. She came by train to Bern from Geneva to participate on this live demonstration, and she thinks that we are the world champions and so on. But when I'm really honest, I think we should have done better than this one. But from the implant resistance point of view, I have no problem with the 2 implants. I know these 2 implants will survive the patient, but the prosthodontic solution, and implant positioning was very poor. Okay. So, and it gave me the occasion to once again insist on the importance of trying whenever possible to implement small segments when we are planning prosthodontically. It's an old rule which has its value. Now I'm coming to the second last paragraph, which is implant complications. And I try not to make it in a depressive way, but you are ready for a few more, huh? Some of them you have seen, you see. Just to insist, some of them I have some sympathy for, and some of them I think should never have happened, because it was just incompetence. And I would like to start with this patient here, who got the implants when she was a teenager, and then they disappeared almost in the floor of the nose. She has a gummy smile, and these were old Hattie implants. That was an implant design which was quite popular in Switzerland, but many years ago it has disappeared from the market. And she has no bone on the buccal of number 12, chronic inflammation there, so no doubt that we have to remove these implants. Will this be a complicated procedure again? They were cemented, these restorations. So we took them off, and again, Professor Buser said we will wait a little bit, a few weeks, for soft tissue, fill in, and then I'm gonna remove these implants, and then in a second surgery, place the new implants. And to make a long story short, that is at the end of treatment. You see, we had a lot of bone loss, but interproximal tissue height was correct. 2 narrow diameter bone level implants and very long restorations. And when you look at the 2 laterals now at the end of treatment, looks great, huh? The only thing is, I told you before, she has a gummy smile. If a presenter at the end of a case presentation shows you the picture only with the lips, that means something is wrong. You can make for sure. So something is wrong. Now you see it. She got, of course, she had 2 surgeries and a little recession on her old crown, number 11. And she can smile and show it, as you can see there. And I said, well, you know, this crown you have in your mouth for 20 years, I think you should do a new one. And then she looks at me, and I said, and also the composites on 21, we could do better. And she said, why? Look where I came from. I'm so happy, because she was so embarrassed by this. She says, any photographs when she saw, because she likes to smile all the time, she said, horrible. And now nobody of my family says anymore, and this tiny little thing there doesn't disturb me. But I'm convinced I will soon see her for the 1-year follow-up, and I will convince her she needs a new crown. Huh? No, we cannot leave that. You agree with me? But what Buser did on the laterals, this is world class. Huh? I mean, really, I'm so happy about that. And this is just great. But it needs a lot of experience and skills, and he had not a lot of space to do it. And yeah, of course. Oh, you will never reach the interface. We know that with Superfloss, you can maybe go at the maximum of 2 millimeters underneath the soft tissue. And so we have just epithelial attachment there, And that is what normally we have. We will never able, on a bone level implant, to reach the prosthodontic interfaces. That's why also this debate that we should not disrupt it all the time, not making so many try-ins and in and out, because this is stable. She will only, at the maximum, going subgingivally or submucosally 2 millimeters. And she's using once a week some chlorhexidine gel, and then use the Superfluss to bring it a little bit up. That's as good as we can do. And luckily, this is not causing a problem. But you know, when you look back at how modern implant dentistry started from P.I. Brånemark, with his, these were all bone level implants. And with interfaces, a deep interface which never could be reached by the patient. And I saw patients with these 6 implant restorations with the cantilevers, with calculus and everything, and still no bone resorption. I think we are very lucky that this phenomenon which you just was mentioning is not apparently affecting osseointegration too much. Otherwise, we would have a huge problem. Yeah, that's for sure.
Was that not a good case for using tissue level?
Yeah, of course, today we would have used NNC implants for that, very clearly. Good point. Yeah. Okay, next one. This is very interesting. No, now we make the coffee break. Huh? Yeah, I'm sorry, I want to stick perfectly on time. The second patient I would like to present you, it's a minor problem, but it's quite interesting and sort of an eye-opener. What we can do today, which was virtually impossible a few years ago. And this is this young patient here. And I just got from Danny Buser the slides which explain the whole story of that patient. She's a young patient, she's I think in her mid-30s, and she was referred to Professor Buser with this complication. A recession on implant site 11, and this is the X-ray. So this is typically a bone level implant, tissue level implant, which had been placed too deep and too far to the buccal. It's always the same and very close to the lateral. And this has created this kind of a problem. Then her restorative dentist had finally tried to save the situation with this, and she is a friend of the family of Professor Buser, and so finally she came to see him, and as you can imagine, he said, the only thing I can do is to remove this implant. And just that you know where we come from, that you understand the whole problematic, but this is the initial situation. And then Professor Buser removed the implant. He did exactly the same. He removed the restoration, let the soft tissue take its place while the patient was wearing removable denture, and then this is how he removed at that time that implant. And this was a mess. He used the Trifine around, you know, because we had no tools at that moment to remove an implant. Today, with the BTI implant, it would have been much, much easier. No cutting away of bone to get rid of this implant. But this is how it had been done in December 2004. So this is now more than 11, no, it's or more than 10 years ago. Then, after having removed the implant, he used this BioOss collagen and the membrane and primary wound closure and waited. That's also something he would not do exactly in this way today. And he waited, As you see, he waited 4 months, and then he placed the implant on that side, and again bios and membrane and primary wound closure. So one surgery to remove the implant and one surgery to place the new implant. And then an ITI scholar from Australia was restoring that implant in May 2006. And everybody was pleased. You see also that the length of the implant, of course you can debate a little bit on the mesial edge of the incisal edge, but otherwise the length was absolutely correct. You can debate about color and form a little bit, but it's still a decent restoration. That was in May 2006. In 2010, he sent the patient to Geneva to me and said, she is very unhappy with this black triangle there. And so I took these pictures and I saw a slight problem with color, a slight problem with form, and a little bit short incisally. So this is 4 years after she had gotten this thing. I see the scar tissue and I see the black triangle. And I took pictures of her. I always go a little bit further back and look how, and there you see it is not dramatic at all, but there is several elements which create visual tension. But is it enough to do something? So we step a little bit further back and I look at her like this. And yes, it's slightly grayish. I see the black triangle a little bit, and I see also a form problem, and again, a slightly short, but at that time, I told her, listen, this is now 4 years in place, and technicians hate to do ceramic corrections after that time, because I tried to do something on that crown, but she said, but the black triangle, and I said, okay, I put a small composite mesial to the lateral. That's all I did. And now, I saw her last year in Bern again. I was happy that the composite was still there, and the shortage, incisal shortage, was a little bit more pronounced. Although she is, I think she's between 35 and 40 years old. And she says, well, you know, I always look in the mirror, I don't like it, it's a lightly grayish, it's a little bit short and the form is not right, can we not try? And the laboratory of Alvin Schönberger, which has done the most of the restorations I've shown you, he had developed a new protocol how you can still do modifications. It's a solution which he keeps secret, where he immerses the crown for I don't know how many hours, and then he dries it very, very slowly. It's a process of roughly 24 hours, and then he removes a little bit of the surface and use low fusing ceramics. And he says, you will see, I can do that. I can correct the form, the length, and the shade. And I told the patient, listen, I found in the box still the old temporary, so never throw away the temporaries of these implants. And if you don't want to have them stocked in your practice, give the box to the patient and say, you never know if you one day will use it. And usually a model with an implant analog, and so that's what the patient keeps. So we had this at the University of Bern. I found it and I put it in the mouth, and this went to the lab. So this was this old ceramo metal crown. And a week later, I got it back from the lab, and he did absolutely fantastic. Now the length is good, the color is good, the form is good, The only thing which strikes us is the scar tissue from all these surgeries. And Professor Buser always wants to talk her into some laser smoothing, and she hesitates. I don't know if it's going to. But this is 8-year follow-up with the correction, and when you look at that, I don't know, it's just perfect. Huh? So I feel much more comfortable also with respect to what I said this morning, that when you have young patients with, you make anterior implants, that you can tell them there is more and more knowledge now how to do modifications also 8 years later. You do not necessarily to have to do a new restoration in all cases. So this makes me a little bit more comfortable, but we cannot do it by telling a patient, you come in, let's say early afternoon, you take a book, I take it out, and the technician will do it, and 2 hours later I put it back. It is something which really roughly takes 1 week, so and so that's why you need to have a temporary restoration. So it was a minor complication, but very elegantly solved for that patient. This is a good one. It started like this. These were the first adjacent bone level 4.1 Professor Buser has placed, and I made this restoration with Alvin Schönberger, and everybody was pleased. Looked okay, huh? But unfortunately, 2 years later, she came and she said, "Oh, I'm so unhappy. It was so nice for more than a year, and suddenly this happened," and she was close to tears because she said she liked the crowns very much. And when you look back at the X-ray, you see this little bone peak which was there at the beginning, apparently it has disappeared. And what question should come up now? Why what? Why what? Why so close? These implants are very close. But why not using smaller diameter? Because at that time, there were only 4.1s available. And Professor Buser had to be very careful not to come close to the laterals, particularly to tooth number 12. You see, we are very close already there. Of course, today he would use diameter reduced bone level implants for that one. Okay, but now what shall we do? There's not much we can do. We are starting to lose money here. That's for sure. So I removed the crowns. She has excellent oral hygiene, and I took impression. And you see what the technician does. He then tries to define a new line of emergence because we knew that the line of emergence of the lateral is a little bit more apical than normal when you compare it to the center. So we thought we can emerge with the centrals a little bit more apical and close interdental area, and by this token create the illusion of a scalloped soft tissue. That was the intention. And now you see the technician grinds this in this way here, just to think that is where he wants that the future restorations will emerge from the soft tissue. Do you think that's a good idea? Yeah. It made sense to me at that time, but I learned a lot by this patient. These are the new crowns. Nice emergence profile. He placed the interproximal contact, but maybe not as palatal as I wanted, but looked okay. And it took me 2 sessions to get at that. Because first I thought, well, I wanted, and he had added quite some volume here and there to get this line of emergence more triangular. But I saw, as soon as I put them in, the whole thing went up. Because when you have adjacent implants, you have not the same attachment of soft tissue as you have on adjacent teeth. If you start to add volume, the whole thing goes up. And so I had to reduce again because I didn't want that, because that was the major problem of the patient, was this one here. And it doesn't look really right, huh? I don't know what is your opinion. But so this is a new generation of crowns, new CAD-CAM generated zirconia abutments, and 2 try-in sessions. And then ultimately I gave the mirror to the patient, and she stood up and looked, and she said, well, it's okay, and replaced it. This is now the 4-year follow-up. See, we still have some bone, apical to the implant shoulder, also in between. We try to be as slim as possible, but with zirconia, you cannot, the first millimeter you cannot reduce, otherwise you weaken it too much. It's typically 2 implants which are too close to each other. And that is how she looked, and then I could take also these photographs. And then the day after I have taken these photographs, she sends me an email and say, can you send me the pictures you have taken? Then I was hesitating long, and then I sent them to her. And almost immediately, she sent me back and say, I found my smile again. So apparently she likes these 2 pictures very much. Although we as dentists, it's not 100% right, huh? I tried to create a little bit more room in between to put the interproximal contact line more to the palate, and that's the maximum she would let me do because she was afraid that some black space would appear. And that is really her normal smile now, and I think it's okay. But I learned a lot again about this adding contour. We cannot, like a snow plow, a snow plow. We cannot just add a little bit and then the soft tissue will just locally do what I want. It is all together. On a natural tooth, probably we could do it much better because the attachment is very different between a tooth and an implant. So the more I look at my pictures and things like that, I learned that it's very limited, and I will show you a case later on which also quite drastically shows what we can do with contour and what we should not do. Still in the field of implant complications, this is a patient who also was referred to Professor Buser because she says, I hate my smile. All the pictures of family gatherings or so, I'm afraid that one can see my anterior teeth look so horrible. And it doesn't look so dramatic. Of course, she has an implant there on both centrals, and we see that already some implant shoulder is visible. I let you judge. She says, I have always my hand like that. It's too big when you compare the laterals, particularly the 22 and 23, to these huge 2 centrals. And she says, and when my lip falls, it creates a shadow. And the black hole in the center. When I look at these pictures, it's not so dramatic. And this is the DVT showing a huge implant position 11 because she told us she had trauma on both centrals. And 11 had to be removed, and her dentist put in an 18 millimeter implant. And when you look now at the cone beam, here we see. It's in the floor of the nose, huh? And she says she can feel it. I don't know, but and then comes Professor Buser in and says she's also somebody he knows from the family. I will take this implant out, and that's why I was insisting on this feature here. Huh? The old Brånemark fixture, they had these anti-rotational features up there. And it's now in the floor of the nose, and this huge osseointegrated implant, and then to crack it. And Boo said, well, no problem, it will go. But when he left the thing, I said to the patient, I would really be careful. It's honest, it's still there, this implant. But basically, he's right. If this would have been shorter implant and without this feature, no problem. But with somebody who's already having some problems, okay. So, took impression and asked the technician to find, and we discovered that there was not only this nasal floor penetration, but it was also a huge axis problem. See, this is the axis of the implant, so the technician called me and said, I make an angled abutment for this patient, and now I have this restoration, temporary restoration, screw retained on implant 21 and cemented on implant 11. I hate that, huh? This even on temporary, and as a permanent solution, this is the worst you can imagine. You have to put the cement in and be very fast with tightening the screw, and really, okay. And I got this with pink, and that is how it looks like. Not the greatest, huh? The more she smiles, the more it gets ugly. And still no access for cleaning in between, so I opened this spot here in the center that she can come with Superfloss a little bit. And that is what we have now. On the top row and on the bottom row is how she came. It's different, huh? But it's not better, huh? It's just different. The size of the teeth is much better, and the black triangle is away. So she went to the mirror and she said, it's much better. Me as a dentist, I must say, the proportions are a little bit better, but still a lot of asymmetry. It's not right like that. Okay, so what is the next step? Now I have a temporary, which doesn't correspond to what I want. Okay, so it's again time for a mock-up. Huh? I took an alginate impression, sent it to the lab of this new temporary, and we were debating on the phone while he has the pictures and I have the pictures, what we would like to change to reduce the discrepancy between these two centrals and the adjacent dentition. And I got this silicon key and I pressed it on top of the temporary, and then we remove the excess and we look at it. It looks again a little bit different, a little bit better. This now doesn't look right, huh? It's so dark here. And I take photographs, always the same magnification, but with increasing smile. The first one looks good, the second starts to hurt, and the third really hurts, huh? Okay, and then you realize the asymmetry of her face. The whole thing hangs to the left, and she has the whole ulvar crest, which is much longer on the left than on the right. And this is something which probably has developed over many, many years because she lost substance on the lower jaw and so forth. But we cannot go and do now their osteotomies or things like this, or intrusion and then crown lengthening. But we see now we have a problem which I would summarize like this. This is creating the most visual tension, this interface here, which we know we will be able to master, and the gummy smile on upper left. Okay, so the goal is always re-establish harmonious conditions and a regularly scalloped soft tissue course and balanced relative tooth dimensions, and we have not reached that. Okay, here you see the smile with that one. The only smile which looks okay is on the right. All the other ones, you see the problems. And she, when I really make a joke, then she can smile like this. And she is such a nice person, and she thinks it's already much better, but it's not good enough. Okay. I did a second mock-up. So we are losing a lot of money here, because you cannot charge this all to the patient. This is just hobby. That is what nice if you are retired, and then you can you have your pension, you see, and you can work on that, and it start to look better, but still not perfect. Okay. Then I went for the final design, and I told you I don't want to have cement and screw retain, so we went to the old Swiss tradition of horizontal screw retention, and I have now horizontal screw retention on implant 11 and normal screw retention on the. So that was at the BISC try-in and just the mock-up to look if we can balance the whole thing. We know that still we have to deal with this one here. I think we are slowly getting there. I hope you agree. I can. Okay. I was disappointed about this interface here, but it's more or less okay. And now she has an appointment with Professor Sculean to make this crown lengthening 22, 23, 24. And then she will get at least the 22 and 23 also veneers on the other side. And so when I come back to Bristol, I can show you things. But this was just a week ago now. But just see how sometimes you have to take time and try and slowly approach what you really would like to have. Next patient. Very disappointed from implant. She got an implant 12 and 11. Today, of course, would have been enough to place just one implant and a cantilever. Would have been much better. Professor Buser removed already the implant 11, and then he asked me, what do you think, what we should do? This implant also has to be removed, and the patient doesn't want any implant surgery anymore. She was treated in private practice. She has an intermediate smile line, but here I force her to smile as much as she can, and she says, I just don't want any surgeries anymore. She knew that this implant still has to be removed, and Buser asked me, have you not a conventional solution here? And she has a very, very small overbite. So we make a mock-up. We just try it in, with pink that is too saturated here, this is wax, and show it to the patient. And she goes to the mirror and she says, well, if you can do that, I will be happy. Okay. Now I told you, bonded restorations, I want only to attach on one side. But here we have 2 missing teeth, so I cannot do that. But I have very little overbite, so I have the whole potential on the central and on the canine for bonding. And so we went for a zirconia framework and CAD-CAM generated. On the screen is the designing, and this is what we got back. And here is the try-in of the zirconia frame. And this is still the blue stage of the ceramics, which will then be used for the pink. And this is what we got. No preparation whatsoever on the teeth. And I'm not very happy. That was the picture I took last year at the moment of insertion, and it looked a little bit long to me. And I saw her last Tuesday, and I took these pictures. She looks a little bit tired, but she's very happy. And she's happy that we had no additional surgeries. I let you judge, but the defect was quite important, but she has it, the concavity, that it's cleansable. She says every day, at least once, she goes through with Superfloss. Looks okay. The zirconia we can only sandblast. Unfortunately, we cannot etch now. So, as I said this morning, that is the most important slide. Don't forget it. That is why we are dental doctors. And that was my first conclusion. I try to convince you that when you look at publications proposing more novel treatment modalities with implants in the anterior maxilla, that means in the aesthetic zone, look if they include in their data the patient satisfaction concerning aesthetics. That's really important. And if they don't, then you should be very careful. I try to demonstrate the validity of early implant placement protocol, that pull the tooth, wait for soft tissue healing, and then open a flap and place the implant with simultaneous contour augmentation. It is maybe not the most attractive protocol, but it's by far the best documented so far. And this may change in years to come, but for the moment, this is. I try to demonstrate that aesthetic potential of platform switching design, particularly when it comes to anterior single tooth restorations or adjacent implants. I try also to convince you that treatment strategy for more extended edentulous spaces should be done with a minimum of implants, work with pontics, with cantilevers, and I have a clear preference there for the tissue level design for purely prosthodontic reasons. And I try also to give some guidelines how to use pink if it's the only way to save a situation and to avoid that the patient goes through a lot of additional surgical procedures, which are quite often not even predictable. I also tried to demonstrate that anterior maxillary single tooth replacement, when you have recessions, you can our possibilities are very limited to treat, and that we should be very careful and think of alternative treatments. And I would like to make one example. If you have a young patient who lost a tooth here, and you see already the first signs of recession, and you see that interproximal X-ray already shows some tissue loss in the adjacent proximal area, then be careful with implant dentistry. Because you want to achieve something which looks decent as to, and what is this? Is this an implant? This is one of these unilateral bonded restorations. Just think about those. Some technicians do it with lithium disilicate. I, whenever possible, use still zirconia because I think I need this additional strength, although bonding, as you just mentioned before, is not as easy as we have it for etchable ceramics. I mean, it's not perfect, but I'd rather do this and gain time than having an implant and eventually put myself in a situation where I know I can virtually not do anything anymore. So when it smells like a patient who has a high risk for recession, then I try to think of all the alternatives first before choosing the implant. And I want to back this up with a recent case where Professor Buser had to remove an implant and he placed a new implant. And then he had placed a tissue level implant this time. And this is when I took over. And I see already that there is mesial on the lateral and also distal on the central a lack of soft tissue. That is what I got from the lab as a temporary restoration, and now we can see that if we try to keep the proportions according to the natural control tooth, it's already a larger tooth. We have huge black triangles. I'm just rubbing it in because what can we do now here? The periodontists have to wake up now and say what they can do here because the implant is there, we cannot take it off anymore, and we have two papilla which miss. Do you think we can go with contour augmentation of the restoration and hope by putting more volume here and here that the soft tissue will come up here, come down? It's wishful thinking. Huh? Okay. So, but I called Professor Skoulean and say, you are such a big shot. What can you do for this papilla? And then immediately he says, well, the papilla, I can probably not improve. What I can just guarantee that I can do that it will not get worse by doing his tunnel technique. But then he said, but for that I need a lot of room to do my surgery. See here, that is the respective X-ray. He says, if you make me a very thin temporary, then I will try. And I can guarantee to give more volume, and eventually this has a positive effect on the canine, on the papilla. See here, that's the situation. So I took the temporary off and just removed the whole cervical contour to make it very, very slim. And this is just immediately after having made that. And now you can imagine the soft tissue will just go for the contact again. And then he made his surgery. It's, I will show you on another case, it's a little bit in more detail. He makes a tunnel, a split flap, and then he takes connective tissue from the palate and sneaks it in. And try on the mid-facial to do that, but also in the papillary area, and hope by this we will get better conditions. This is after the surgery. This is 2 months after surgery. And I added volume again to look if this is better. Is it really improved? What do you think? It's not fantastic, huh? Close-up view. And then finally the patient was tired and I was tired. I took final impression. This is several months later. And this is now the final restoration. And you see, I still have a black triangle in between the two centrals and also a lack of soft tissue. I mean, quite a dramatic lack between the lateral and the center. So the provisional restoration and the final restoration. I can see a little bit of improvement, huh? Particularly in between the two, there I'm actually quite happy. Between the two centrals, where I'm very disappointed is the distal. And that's what we do in Bern. Huh? It's just frustrating. I mean, a nice patient who says, well, but we didn't promise anything. But when I'm really objective, I must say the restoration is now beautiful. It's as good as we can do it. And we can hope that within the next year or two, we will a little bit, it will evolve positively, that I know, because we have the volume now. But we don't think that we have tools today to predictably reconstruct papilla around an implant. That's just important that we, knowing this, we should be a little bit more less optimistic sometimes when we have edentulous single tooth spots here in the anterior maxilla. And along these lines, a recent case also, one of the graduate students of Professor Buser, just before leaving, after finishing his 3 years program, he came to me and said, well, I have a patient where I put bone level implants for a referring dentist in private practice, and he restored it, and the patient called me and said that she hated the crown and that she will not continue, and she didn't want to go back. She had paid the crown to the dentist, and she says even if she has to pay it once again, she wants to have it changed. You see how different we were debating this yesterday evening. In some areas you have patients who, if it looks more or less like a tooth, then say, well, that's good enough, huh? And I like these patients, huh? And then there are some which, when I look at these pictures, I see, where is the problem? Huh? I've seen much, much, much worse than this. Huh? But she has a gummy smile, and she says, look, it is longer on the cervical, and it's not good. When I look at these pictures here, I can hardly see. Of course, I see a little discrepancy between the two, the natural tooth and the canine and the implant restoration, but nothing dramatic. Anyway, we got Professor Sculiar, and he looked at it, and I said, I will not modify that crown because I want always to be able to go back to that. If we do something, I want to place a new temporary, and then we work with that, and we keep this untouched. I would love to modify a little bit, to reduce the cervical profile and to reduce the mid-vestibular, but it is a cemented restoration. So I made a hole on the palate to get to the screw, to take it off, to keep it like that, and took a new impression, and this is the temporary which Sculiar needs to make his surgery. And you will see it's very interesting to watch that. That's what I got from the lab. And this is just a few minutes after having removed what she had, ceramics, and put this in. And look now what happens. Look at this beautiful papilla here. And within a few minutes, we come to that. So that shows me in the proximal contour, still, if it's on the right plane, allows to have the right thing. And now it collapses. You see the hole which has been created here. Within a few minutes, just by having less contour here. So it's puzzling that still we can, apparently, it's not the snowplow which I was mentioning, but we can a little bit direct. So I know this I will be able to do again with this, that's for sure. But on the distal, you will see a little bit more complex. And she stood up, went to the mirror, and said, well, it's an ugly crown. Well, it's only temporary, it's a little bit grayish, that's for sure, but we needed to make a spot for Scullion. And here you see his technique now. He makes a tunnel, split flap there, and that is the connective tissue. He harvests from the palate, and he very gently sneaks it in and fixes with his sutures. The periodontist in the room, do you think that makes sense? Or is it human trials here? You see, we are on a very dangerous discussion now. What we should do and I cannot tell you everything, what we discussed with this patient, but she said, I want that you try everything to improve the situation because I hate this a lot. This is after healing. The central situation, I know I will be able to improve by placing a final restoration again, but I think we have lost on the papillary area between 12 and 11. This is the comparison. That is how she came, and that is how she is now with the temporary. Even with a lot of positive thinking, I can see a little advantage mid-facially. I know the papilla will be there again where I wanted to have it between the two centers with the final restoration. I'm quite worried about the distal. This has not improved at all when I compare. That's how she came. This is worse now. This area is better, and this I know it is similar. But it's a new temporary and surgery. Is this ethically correct? But when I have a patient who comes with this, I talk exactly to her like that and say, we have no proof, no studies, no nothing. We have just an experienced periodontal surgeon who is willing, if you wanted to try, and he says that's the only protocol that he is willing to do. And because he also wants to see if in implant dentistry, after having placed the implants, after having a recession on an implant crown, if he can do something. So we are building up our learning curve on patients who are well informed and want to take the risk. But he says, on long term, we have gained here. This process, which she hated, was probably going on to worse, and now we have stopped it. And you have to invite me in 2 years, then maybe I can show you if this is really something. But to rub it in once again, we have not predictable, elegant solutions which can afterwards correct papilla loss and recessions. The next conclusion was multi-unit FTPs. Pink power is a concept, not a last resort. we have to implement strictly the rules, the design rules. And I'm convinced that PINC can, in many instances, save a desperate situation and can avoid the patient additional surgeries which are not very predictable. I hope you can still, I'm jumping from one to the other, but I think PINC is part of the treatment modalities today which we should consider when we are dealing with multiple unit missing teeth which have been replaced by implants. And by this I want once again say, the profile has to be convex, that the patient can efficiently clean. No double papilla. PINC as pale as possible. Make it screw retained, directly screw retained, so that we can always remove it and clean it if necessary. Then, when you do it correctly, you can come up with quite some nice result. Team perspective, very important. That we try to put together the expertise which is necessary in a given situation, and that everyone tries to contribute the most to that one. And these are all the acknowledgements to all these people who have, in a form or another, during my career, contributed something what I could show you today. And by this, I would like to thank you very much for your kind attention, and we use the last minutes for some questions if you have still some energy and power. Thank you very much for your kind attention.